Hello, my name is Andy. I'm the Resuscitation Officer for Shropshire Community NHS Trust. I'm going to run you through some of the small changes from the Resuscitation Council that affect our basic life support and immediate life support training. So the first one is a change to the process of calling 999. Before, we had emphasised that what you must do is ascertain the patient is unconscious, and once you've done that, we're going to safely open their airway and then check their breathing. If they're not breathing, call 999. But that's changed. They've actually made it earlier in the process now to call 999. If you ascertain a person is unconscious, now is the time to call 999. You know you're going to need help at this point anyway. But they've made an emphasis on that early call, and you then still have time whilst the call is connecting to check whether the patient is breathing. And if you have any struggles with checking their breathing, the point is the call handler can take you through the process of doing it. So first question they ask when you come to call an ambulance is the patient breathing? And if you say, I don't know, they will take you through the process. That is the point, okay? The second thing is this, they've made an emphasis on rescue breaths or ventilations as a really important part of basic life support. So previously you may have been taught that it's very optional to do breaths and hand-only CPR is okay. And they're re-emphasising the importance of breaths. So if you are willing and if it's safe to do mouth to mouth, they're saying please do it. Okay, they've ascertained the risk is very low unless there's a known respiratory problem or perhaps you're vulnerable, the risk is very low. So generally encouraging that. If you have been issued with a CPR mask or a CPR shield, that will give you some protection if you're going to do the breaths. And then of course in our clinical areas, not in our community areas, you might well have access to a bag valve mask. Okay, so this is going to do your ventilations. No mouth to mouth will be necessary in those clinical areas. Okay, so really pushing the fact that we should be doing 30 compressions, 2 breaths, 30 compressions, 2 breaths. And then of course in a child or under 18 it's 15 to 2. Okay, it's more oxygen in, more carbon dioxide out for children, so 15 to 2 for under 18s. Okay, right. The third change is to the AED pads. Now we've already been teaching this on SHROPCOM courses, but it's the placement of those AED pads is really important. So picture on the pads, this one is always going to come up here under the right clavicle, right at the sternum, and with our Zoll AEDs, the yellow AEDs we have in our clinical areas, it puts a puck on the middle of the chest for you to do your CPR on. In the community, any type of defib might turn up, it might not have that puck, but still the pad goes up there. Okay, what they're really emphasizing is the importance of putting this one, the second pad, in the right place. Okay, and it should be right on the side of the patient or the axilla, right under the armpit. So a couple of fingers below the armpit, 2 centimeters below the armpit, right up there. Okay, we teach the public it's lower down, and actually the picture on the pads is a little bit lower down, but you should be putting it up here. It's better because your heart sits here and we want the electricity to go through the heart and come out the other side. So that pad placement, really, really important. Get it high and on the side. One other thing they've said is consider this. If you've given 3 shocks, consider changing the location of the pads. So if you recall from where we put the pads on paediatric patients, it's front and back, isn't it? What they're saying is if you've got an adult patient who you've given 3 shocks in this position, perhaps that's not beneficial. Perhaps we need to move the pads into another what's called vector, another direction for the electricity to flow. That's worth a go if you have time and skill set and enough people to do that. Massively beneficial. Okay. There's been a change to the CPR directions for infants. So this is babies under the age of 1. That's what's called an infant. Okay. Before, the teaching was you could use 2 fingers or encircle your thumbs to do CPR. They've got rid of the 2 fingers. It's less efficient. Okay. Now it's encircle thumbs. So you're going to put your hands round baby, encircle your thumbs, put your thumbs on the sternum there. And we're going to do 15 to 2 like that, okay? If it's a very small baby, you can put your thumbs on top of each other. But that is the technique we'd like you to be doing. So 15 to 2 for babies and infants like that, okay? And then the guidance stays the same for slightly larger children. We're going to use one hand, centre of the sternum. However, If you are not strong enough or the child is too big, use 2 hands. It's whatever you need in order to affect that CPR. And how deep are we going to go for kids? Well, it's a third the depth of the chest. Okay, up to 5 to 6 centimeters. On an adult, it's 5 to 6 centimeters, 2 inches. On a child, obviously they're smaller. Scale that down, third the depth of the chest. Okay, so whatever you need to get that depth, that's what you do. Might be 1 hand, might be 2 hands. Okay. So that's your 5 big changes in the Resuscitation Council guidelines for 2025. We will be implementing those through basic life support and immediate life support training. If you have any questions, approach me, approach one of the clinical skills trainers, or ask on Staff Zone. Absolutely fine. And I look forward to seeing you at life support training. Thank you.